Kia ora everyone, and welcome to our Goodfellow webinar on shingles and Shingrix. My name is Dr. Courtney White, and tonight we'll hear from two speakers, Dr. Buzz Burrell, a GP and pain fellow at the Auckland Regional Pain Service, and Dr. Joan Ingram, an infectious diseases physician and medical advisor at Immunisation Advisory Centre, IMAC. So I'll now hand over to our first speaker, Buzz. Thank you.
Oh, thank you very much. And look, thank you, anybody who's listening, for your interest in this topic. It's fascinating for two reasons. One, postherpetic neuralgia is really, really common, and I'll explain why. And secondly, it gives me a chance to almost evangelize on the concept of chronic persistent pain, because the principles for looking after postherpetic neuralgia really are extrapolatable for almost any chronic persistent pain condition. So what I intend to talk about is what exactly is postherpetic neuralgia, and it's like all things, it has a specific definition. Chronic persistent pain principles in general, and then we'll look at the postherpetic neuralgia in particular, and then finally the treatment of postherpetic neuralgia, and that hopefully should segue beautifully into the second part, which I'm really looking forward to hearing. So look, we'll start with what exactly is postherpetic neuralgia. Now I'm going to tell you what you already know, and hopefully follow it with just a little bit more, which you don't. As you know, it's we pick up chickenpox now. Nearly all of us, certainly of my generation, would have picked up chickenpox. Interesting enough, when people are vaccinated, of course, they won't anymore. The chickenpox, we pick it up and we get over it. And then the viruses, they hang out in this dorsal root ganglion. And the top part of the slide there is just to try and remind you where that DRG is. And it's just inside the bony part of the spinal of the spine, and it just sits there. And then, for whatever reason, when it gets bored, it'll then march itself down the very nerve which it marched along in the first place to live in the DRG, and it will give us exactly what we all know, that shingles at the bottom there, that's classical shingles rash, which of course will have to follow the dermatome of the DRG in which it was living. So how do we define it? And it's classically defined as a chronic pain, i.e. lasting more than 3 months. And that's really quite important. I saw a referral not too many weeks ago from someone. They'd had shingles only for about 3 weeks, and the diagnosis was postherpetic neuralgia. And that was amazing foresight. They may well have gone on to develop it, but they hadn't got it yet. So it's 3 months of chronic pain with skin changes in that distribution of one or more sensory routes subsequent to that zoster infection. And if we can stick with that diagnosis, then we're all singing on the same song sheet. So a different way of wording it, however, is what is it? It's common, and that's probably the most important thing. As you'll see here, 1 in 3 adults are going to get shingles, and 1 in 2 adults over the age of 80 are going to get shingles, and 1 in 3 of those people are going to get postherpetic neuralgia. So this is a really, really common condition. This is the opposite of unusual, and therefore we really need to have a respectable handle on it. The risk of developing certainly starts ramping up in anybody who's over 50, and the reason for that is, unfortunately, people of my generation and older, as we get older, our cell-mediated immune response just gets less and less. In other words, we become immunodeficient as we get older. All I can say is apparently. So the rider to that, therefore, is anybody who's immunocompromised. Similarly, is going to get shingles and then postherpetic neuralgia. But anybody over 50, I'm afraid we've got that 1 in 3 risk, and then the 1 in 3 risk. But certainly this. So therefore, the risk factors: older age, as I said, over 50. Females, I hate to say this, it definitely prefers females. And then the risk of actually the postherpetic neuralgia part. So the top bit, older age female sex, is the risk of getting shingles, but the risk of then getting postherpetic neuralgia after it. And look out for these signs at presentation. But if the pain of the shingles itself is very intense, if the rash is particularly severe within 3 days of the onset of getting the shingles, and certainly anybody who's got a prodrome, constitutional symptoms which are part of getting the shingles, that is hello, I think you are going to develop postherpetic neuralgia, and I'm going to be on the lookout for that. So let's then move on to the chronic pain principles in particular. And this bit is particularly interesting for me because it is, as I said, it is extrapolatable. So how do we feel chronic pain? To understand chronic pain, we really need to understand where is chronic pain coming from. So I'm just going to show you this one slide, and it's pleasantly complicated, but hopefully I'll translate it into English. We've got a big brain at the top there, and at the bottom there, I think looks like a squashed frog. That's an attempt to try and look like a cross section of the spinal cord. And what we're looking at with those two little diamonds there is the beginning of the second order neuron. Now, off screen therefore is the first order neuron, which is going to be the source of any sort of pain. Now, if we've got an acute nociceptive insult, could be anything, stubbed toe, bee sting, broken bone, you name it, the first order neuron at the end of there will fire off, and it will land in that dorsal horn at the back there where those two little triangles are. They're the beginning of the second order neuron, and off we go upwards, and that is the spinothalamic tract, so named. That's a cross-section of spine, and up it goes to the thalamus. Now then, you'll see between the thalamus and the postcentral gyrus, that little heart-shaped thing at the top there, the red bit is the postcentral gyrus, S1 written by it, and that's where we're going to feel the pain. The journey between the thalamus and the postcentral gyrus is necessarily complicated, and there's a handful of ganglia and nuclei are going to try and modify those signals, a little bit like the signals arrive in the back of a TV screen before it reaches the front of the TV screen and can watch it. Now, to a certain degree, that's a very useful analogy, and certainly when patients are saying, so I've got chronic pain, and he's saying it's all in my head. To say it's all in the head, we've got to be careful how we word that, because yes, it is in your head, of course it is, but to say it's all in the head and you're making it up is a little bit like blaming the TV screen for bad acting. And by the time it reaches S1, all S1 is doing is just receiving messages, and that's a TV screen with the bad acting or otherwise upon it. But what I want to draw your attention to not only is the prefrontal cortex, which is going to throw in its memories and the significance of what's happening and all the other nuclei we're looking there, but you'll see just below the thalamus is that thing, the PAG, periaqueductal grey matter, and I'm going to refer back to that in a short while, but I just wanted to bring your attention to that as we look at that slide. So to understand chronic pain, we really do need to try and understand the difference between acute pain and chronic pain, because they're about as comparable as a tadpole to a frog. They're genetically similar, but they're wildly, wildly different. So to just orientate you again, just reminding you and reinforcing what I said, we've got the first order neuron, which is the source of pain, that goes off to that cross-section spinal cord. We saw the diamonds before in that dorsal horn, the second order neuron, off it goes to the brain. And I'm just going to look at that slightly differently, because probably the most important thing to get in our heads, the difference between acute pain and chronic pain, is that little bit I'm showing in the square there. That's the dorsal horn, and that's the exciting bit. So to orientate you, if you can imagine that yellow nerve we're looking at there is the first order neuron, and then the gray nerve is hooning off to the brain. So basically, for the purposes of simplicity of this slide, this person is standing on their heads. And I'm going to look at that synapse just a little bit more in detail. So this is deliberately complicated, but I'm going to make life ever so slightly easier and split that up into acute pain and then chronic pain. So for the acute pain, we get the nociceptive insult just above the screen there. It comes down, and there you'll see glutamate and little packages that's itching for an excuse to get squirted across and caught by the second order neuron. And if you look at the receptors there, you'll see they're caught by these AMPA receptors. They grab hold of the glutamate, say, you've had an acute nociceptive insult, I'm going to tell the brain about that. And off it fires down on the spinothalamic tract journey. But just have a look to the left there. We've got these NMDA receptors. They're quiet. They're not happening. They're plugged with magnesium, and they're sitting there with their arms folded, just waiting for an excuse to piss the owner off. And then if we continue to stimulate that, eventually those NMDA receptors are going to say, yep, that's why God put me there. And they're going to join in and then make the difference between acute pain and chronic pain. Now, with the chronic pain, you'll see there's a few differences. The first thing is we actually have a hang of a lot more glutamate hanging around. Secondly, substance P joins in. But probably most importantly, you'll see the magnesium plug has fallen out of that NMDA receptor. And now that NMDA receptor is the neurotransmitters receptor, which is telling the brain. And there's a couple of things about that NMDA receptor which we need to respect. The first thing is it can function autonomously. It can even forget about the fact it's got a first order neuron annoying it. And to a certain degree, that is the beginning of trying to understand phantom limb pain, i.e. the foot, which was amputated 5 years ago, is still hurting. Now, of course, the foot isn't there, neither is the first order neuron, but that NMDA receptor, which was annoyed when the foot was attached and was about to amputate it, became autonomous and is continuously telling the brain that we still have a painful foot there. The second thing about these NMDA receptors is they phone a friend, and there's neurons alongside this, and the NMDA receptor will phone them up saying, I'm telling the brain about pain, do you want to join in? Now the nerve next door might say, well, yeah, but you're from the foot, I'm from the knee, does that count? And the NMDA receptor will say, no, you tell the brain as well, and we'll make the foot and the knee hurt, why not? And suddenly we're starting to have spreading pain. And so again, we've, especially people with chronic pain, how many times have we seen it? They have a broken toe, and then X period of time later, more than 3 months later, the entire foot hurts, if not the leg hurts. And that's the beginning of the problem, that nasty little unplugged NMDA receptor. And there is a difference between acute pain and chronic pain. So how does that tie in with postherpetic neuralgia in particular? So we'll now come back to the purpose of this talk. And to do that, we just need to understand a little bit more about that first order neuron, that neuron which is transmitting pain signals from the source of pain to the junction at the dorsal horn. And that nerve itself, it's got different fibers in it, and there's a very crude rule of thumb. The bigger the fiber, the more myelin it's got, the faster it's capable of transmitting. The smaller the fiber, the less myelin, if not no myelin, the slower it transmits. And it's for reasons which are vaguely curious, it is the smaller, less myelinated, if not unmyelinated ones, which are going to be transmitting the pain. And in particular, just bring your attention to these A beta fibers, and they're really quite cute because they if you tickle somebody with a feather, it's the A beta fibers which are going to be telling the brain, I've just been tickled by a feather, and that was a desperately pleasant experience. So what does that mean for PHN? Well, what it means for postherpetic neuralgia is the following. Now, I just want you to have a look at the top half of this slide to start with. And there we've got two different fibers inside the same nerve. We've got a C fiber, an unmyelinated fiber, that's at the very top there, and that is capable of telling the brain, I have felt pain, I'm going to tell the brain I've felt pain, and off it goes to the synapse on the right-hand side. And then underneath it, but inside the same nerve sheath, we've got an A beta fiber, and that is capable of feeling a feather being tickled. And the synapse really can tell the difference. So if we've got a nociceptive input, that will go to the synapse waiting to feel pain, and if we've been tickled by a feather, it will bypass that and go off to its own synapse and say that was tickled by a feather. That's what happens normally. I just want to draw your attention to this little interneuron, that little connection between the A beta fiber and the C's synapse, because all else considered under normal circumstances, that is inactive. That's just there as a curious little sort of why not? Well, why not is a really good question, because when we get a sensitized central nervous system for whatever reason, that interneuron suddenly becomes active. And then what happens is, if we tickle the A beta fiber with a feather, not only will it tell the brain it's been tickled by a feather, but it will jump over and it will also tickle that synapse, which is really designed to listen to the C fibers, the pain fibers. And so with central sensitization, and particular allodynia, being tickled by a feather feels like having a blowtorch put on the skin, because suddenly the feather nerve is landing on the wrong synapse, and the synapse thinks that we've got a blowtorch or a nociceptive input. Now, with postherpetic neuralgia, that C fiber in effect dies off. So now the only fiber we've got then is the A beta fiber, and that's got two jobs: to be say we're tickled by a feather and feel pain, and it gets blissfully confused. It's going to go straight to the C fibers synapse anyway. So any stimulation of that A beta is going to be perceived as pain, and that's exactly what happens with postherpetic neuralgia. Suddenly, the skin, which should have clothes on it, have shoes on it, have socks on it, or somebody giving somebody a hug or being stroked, all of those stimuli are horrible, and all of those stimuli are perceived by that synapse to be a nociceptive, unpleasant experience, and that's allodynia, and that's postherpetic neuralgia, and that drives our patients nuts. So what is the pain like? It's classically described as as either continuous or intermittent. It can be either deep or superficial, because basically we've lost the C pi, but we've lost a few words of translation. Now we've got a much more basic sentence. Throbbing, burning is an absolute classic one. And classically, again, it will increase during the day and be particularly bad at nighttime, which is just cruel, because at nighttime the skin is covered with bed sheets and the person wants to sleep. And therefore, not only wearing clothes during the daytime is bad enough, but the sleeplessness just amplifies pain in its own right, especially if it's sleeplessness because lying in bed, the entire skin is saying, I hurt. So as a result of that, many patients become the following: isolated, they can't go out, their clothes hurt, they're depressed or anxious, and that's what happens with chronic sleep deprivation. They lose weight, they develop chronic fatigue, but the entire central nervous system starts to get sensitized. Not unusual, therefore, to lose their appetite and to lose condition. And needless to say, as I've said before, the sleep is one of the earlier casualties with this. So what can we do about it? And again, we'll go back into first principles, but just to remind you of that difference between acute pain and chronic pain. And I love this Gary Larson cartoon. But basically, the drugs we give for acute pain don't work for chronic pain, and in particular morphine. And we sort of, I love that sort of pain, morphine. More pain, more morphine, morphine, and the Gary Larson one, shoot. Unfortunately, our acute pain drugs are wrong for the chronic pain. Well, that's nice to know what we don't do. So what can we do instead? Well, initially we can try and jump on it as soon as it hits us, and certainly within the first 72 hours we can dive in with the antivirals. The valacyclovir and the acyclovir is really important. Steroids have a role. Ironically, of course, if you immunosuppress, you've got a risk of developing it, but once you've developed it, go for it. And a short course of steroids may shorten the duration and severity of the disease. Unfortunately, the research at the moment is showing that it does not influence the development of postherpetic neuralgia, but was certainly to make the initial insult as short and as least horrible as possible is a really good start. So the actual pain itself, however, we've just got to remind ourselves we have this this nociceptive input which dies off, and therefore now we've gone into chronic pain. So what can we do? Simple ideas is worth a try, but to be honest with you, unlikely they'll work. What we really need to do now is get into drugs for neuropathic pain. And herein lies principles, and I'm going to simplify this totally unnecessarily complicated slide. But what I want to show you with this slide, however, is that we have two pathways. Now, I mentioned before, we've got that spinothalamic tract, that into the spine, up to the thalamus. I'm going to call that the upward pathway, but we also have a downward pathway as well. And you may remember a few slides ago, I said, look out for that PAG, that periaqueductal grey matter. That is a really nifty part of our central nervous system. If we can stimulate noradrenaline production in the PAG, we activate descending signals, and those descending signals are inhibitory. They're our natural painkillers. But if we can turn that downward system on, that in turn will try and interfere with that interface between the first and second order neuron, especially the second one, and say, can you please stop sending signals back up again? So in very simple terms, therefore, therapeutically, if we think of an upward system and a downward system, if we simplify that slide I've just shown you, we have an upward system which we want to try and turn off. And by turning it off, that's where the gabapentinoids come in. And so pregabalin and gabapentin, what is interesting is that one man's meat is very often another man's poison. And so pregabalin suits some people and gabapentin doesn't, and vice versa. So we're allowed to trial and error. But that's shutting the upward system off is the gabapentinoids. And then we want to try and switch on the downward system, that inhibitory system, and that's where the noradrenaline reuptake inhibiting antidepressants come in. And it is important that the noradrenaline reuptake inhibiting antidepressants, unfortunately, the SSRIs are going to be relatively ineffective. Serotonin as a PAG activator is unimpressive. So we need to try and boost noradrenaline. And I won't offend your intelligence, but the tricyclics are the oldest and one could argue possibly the most potent noradrenaline reuptake inhibitors. But coming down, we of course have venlafaxine, bupropion, mirtazapine, and they're probably the ones which we can go for. And then of course we have synergy between the two, and so we're allowed a gabapentinoid plus an NRI. We can sometimes mimic noradrenaline, and an alpha-2 agonist shape or form of clonidine can either be added or substituted on the right-hand side of that ledger to try and activate the descending pathways. Don't forget capsaicin. It's not just a very painful thing you put on the skin and burns. It genuinely has some fantastic neurobiology behind it. Lands on one of these TRPV1 receptors, but it depletes substance P from the nerve ending. And you remember that earlier slide when I said with the chronic persistent pain, substance P really joins in and starts squirting. And capsaicin will deplete that substance P reservoir. And it will also cause a reversible loss of the epidermal nerve fibers. In effect, they pretend as though they've been killed off by the capsaicin. So capsaicin really has a role, and the neurobiology behind it is pleasantly worked out. But you may recall I also pointed out the patient's isolated, depressed and anxious. They've got weight loss and chronic fatigue. They anorexia and losing condition and the sleep disturbance. And annoyingly, one of the rules of chronic persistent pain, even though I've just thoroughly enjoyed talking about the neurobiology and where we can pharmacologically interfere, the research shows that our pharmacological input is a small part of the battle, and the non-pharmacological input for all chronic persistent pain is probably the lion's share of what we do. So if we just do drugs and nothing else, we're probably in for an unrewarding journey. And we just need to acknowledge that if we're looking at the biopsychosocial model, which is now being turned around to be the socio-psycho-biomedical model, if we ignore that psychosocial part of it, we really have ignored an enormous part of the bigger package of looking after these very often are long-term chronic persistent pain patients. So although I've looked at how do we treat it, we can treat it acutely. We can look at the post-hepatic neuralgia parts with neuropathic drugs and the psychosocial model. Really, prevention is by far the best thing we can do. Prevention is something which is really common. And as I said before, 1 in 3 adults, 1 in 2 over the age of 80. And of that cohort, 1 in 3 are going to get PHN. So if we can prevent that, then everything I've just said hopefully will become historically interesting of what we used to do as opposed to what we should be doing. Now, the next couple of slides I'm going to fly over because they're going to be put across so much better by a wonderful next speaker, Joan. So now I'll be quiet. I really look forward to your questions. So thank you for listening thus far.
Thank you very much, Buzz. So I'll now hand over to our next speaker, Joan Ingram, and we'll go through some questions after she's spoken. So thank you, Joan.
So I'm going to talk about Shingrix, the new vaccine. The vaccine itself, its efficacy, effectiveness, safety, and then run through some common questions that we get asked. So just before I do that, zoster vaccines are different from most other vaccines. Usually we give vaccines before people have met a pathogen. They're still susceptible to it. Whereas zoster vaccines are quite different. We're giving them to those already infected. They have the virus in the dorsal root or cranial nerve ganglia. And so they're therapeutic vaccines, zoster vaccines, hoping to induce a more potent immune response and thus prevent reactivation of that latent virus. So the Shingrix vaccine, it's an adjuvanted ASO-1b recombinant varicella zoster virus glycoprotein E subunit non-live vaccine given in a 2-dose schedule 2 to 6 months apart. It has the adjuvant, which is designed to enhance both the cellular and humoral responses. And it's funded for 12 months after someone's 65th birthday, and it's recommended but not funded for anyone aged from 50 years and individuals with immune compromise from 18 years. And I'd also add to that people who you know are going to become immunocompromised, because people with immunocompromise have a much higher risk of shingles. And so if you know somebody's going to be immunocompromised, try and give them Shingrix before they are. So you can go to sleep now. That's really that's the talk, basically. A bit more detail though, glycoprotein E is the most abundant viral surface glycoprotein in the varicella zoster virus and in those cells infected with it. This glycoprotein is essential for virus replication and cell-to-cell spread, and is an important target for our immune responses. So it's a bit like the spike protein that we've all heard so much about for COVID. The adjuvant contains 2 immunostimulants that work synergistically to overcome immunosenescence of age or immunocompromise. And these 2 things are combined within liposomes. The first thing is QS21, which is derived from Chilean soapbark trees. And the other is monophospholipid A, which comes from Salmonella, Minnesota. And the combination of these produces an enhanced immune response by stimulating the innate immune system. So the MLP interacts with the dendritic cells via toll-like receptors, and the QS21 interacts with monocytes. And the innate immune system is very important for driving our subsequent adaptive immunity and responses to a vaccine. So in the vaccine, we have the IgE, which elicits the immune response, and the AS01, which enhances the immune response. And so the vaccine stimulates robust and specific antibody and T cell responses, as I'll show you with the efficacy study. So there were 2 big phase 3 studies, Zoe50, so zoster vaccine effectiveness study for people aged over 50, with 16,000 people in the study, and Zoe70 for those aged over 70, with nearly 14,000 people in the study. And because the outcomes were the same in the 2 studies, they combined the data. And the vaccine efficacy was 41% against the incidence of zoster overall, and 89% against postherpetic neuralgia across all age groups, which is a big difference from the Zostavax, which has poor efficacy in older age groups. And the reduction in postherpetic neuralgia is thought to be simply from the reduction in the risk of getting shingles. So the very important thing is that it works at all ages. And the study participants have been followed up. The first study was for 3 years, but they've been followed up for up to 7 years now. And efficacy has been sustained out to 84% at 7 years. And it's predicted, with the way the antibodies are looking, to last 10 to 15 years. So much longer protection again than Zostavax. And here's a graph from the Zoe50 study. They had nearly 8,000 people in each arm, and they were followed up, say, for a mean of 3.2 years. And there were 6 cases of zoster seen in the vaccine recipients and 210 in the placebo recipients out to 3 years. So their rate in the vaccine recipients was 0.3 per 1,000 person years, compared with 9.1 in the placebo group. So that gave the very high efficacy. And effectiveness in the real world is similar. One study involving about 1.74 million people found the vaccine effectiveness of 2 doses against zoster was 85%, and 86% if you're age 50 to 79, and 80% for those over 80. And another study found that giving the second dose later than 6 months didn't impair the effectiveness. So vaccine efficacy for those who got their second dose within 180 days was similar to those who were vaccinated with their second dose beyond 180 days. The 1-dose vaccine efficacy was 57% out to 6 months. Now, as we know, the risk of shingles is very much higher in those with immunocompromise, and we are not able to give Zostavax to people with immunocompromise. However, this vaccine, Shingrix, can be given to people with immunocompromise. It's been shown to be safe and immunogenic in people after autologous hematopoietic stem cell transplant, in patients with solid tumors, both before and during chemotherapy, although it's more effective before chemotherapy, in patients with hematological malignancies, in people living with HIV, in chronically immunosuppressed renal transplant recipients. So studies have been done in all these groups, and good responses persisted for at least a year after vaccination. There were some concerns about the adjuvant being a possible trigger for graft versus host disease, but there has not been any evidence of this in studies. However, rituximab does very powerfully impair people's responses to vaccines, including this one. So turning our attention to safety, people must be aware that the adjuvant is fabulous at enhancing the immune response, but there is a similar increase in reactogenicity. The adjuvants stimulate the innate immune system, as I said, and so all these inflammatory cells come to the site of the vaccine, and a lot of mediators are released by these cells, leading to increased blood flow, and the mediators are then taken around the body. So you get local swelling, redness, and pain, and you may get systemic responses such as headaches and fever. So here's data from the Zoe 70 study, and in blue are the Shingrix recipients, and in orange the placebo recipients. So you can see any reaction in nearly 80% of the vaccine recipients compared with 30% of placebo recipients. Pain is the most common local symptom, is also redness and swelling. And then amongst systemic symptoms, fatigue and myalgia are around 30%, headache, shivering, fever, and also gastrointestinal symptoms. And I can vouch for that one. I had quite marked nausea the day after both my doses. These reactions are seen similarly, similar rates for dose 1 and dose 2. And generally they're grade 1 or 2, about 3% are grade 3, and they usually last 1 to 3 days. And in the study, serious adverse events, potential immune-mediated disease, and deaths were all equal in the placebo and Shingrix recipients. And post-licensure safety data monitoring has been consistent with what was seen in the trial. So this report here is the first 8 months of use in America with 3.2 million doses given, and there were no unexpected patterns detected in or any serious adverse events. And so the findings for this time period, they felt were consistent with the safety profile from the trials. However, there have been reports of Guillain-Barré syndrome, and you can see here this clustering between day 7 and day 14 after dose 1. This is medical record review Guillain-Barré syndrome cases. And the Immunization Advisory on Immunization Practices in America had a meeting to discuss this last February, and it's felt that there is a risk of around 3 cases of Guillain-Barré syndrome per million doses. Our data sheet says the available information is insufficient to determine a causal relationship. The ACIP meeting did a risk-benefit analysis, and they felt that the benefits of the vaccine outweighed this small risk. However, they want to continue monitoring it in their systems. Now, turning our attention to some common questions we get asked. First of all, can it be given with other vaccines? And Shingrix is okay to give with influenza, Pneumovax, and Boostrix, other vaccines that older people may be having. However, we don't advise giving it with another adjuvanted vaccine. So here we have Nuvaxovid, which has a different adjuvant, and Fluad Quad is also an adjuvanted vaccine. And so hasn't been studies done with people getting 2 adjuvanted vaccines at the same time. So it's suggested that they should be separated by at least 3 days. We don't have a lot of information about Shingrix with COVID vaccines, and you might get additive side effects, and it's hard to differentiate between which vaccine caused them. So it's better probably not to give them together, although they can be given together if need be, but not the Nuvaxovid because of it being an adjuvanted vaccine. So basically just try and, this Shingrix is adjuvanted, so you want to preferably not give it with other adjuvanted vaccines. Should Shingrix be given to people who've had shingles previously? And people can get recurrent shingles. A good Australian study followed people over the age of 45 years prospectively, found that overall the chance of getting zoster more than once is very low, only 0.35 per 1,000 person years. However, amongst people who've already had zoster, their recurrence rate is higher than the overall episode risk of shingles. So in the people who've already had shingles, they have a risk of 11 per 1,000 years compared with the whole population whose risk is 9 per 1,000 years. And the risk of recurrence is higher in women than men and in younger than older participants and in the immunosuppressed. The mean time for recurrence was around 2 years for those aged 45 to 54 and longer for those who are older. And this is a graph from that study. You can see this is 12 months here. The risk of recurrent zoster is relatively low in the first 12 months, but then it plateaus and sits at the same rate. And at the top here is women and lower is men. So women have a higher risk of shingles and they also have a higher risk of recurrent shingles. And this, because in trials, people who report a history of previous zoster are excluded, there has been a study done specifically looking at giving Shingrix to people who've already had an episode of zoster. And they found that their immune responses were similar to that seen in those with no prior history of zoster, and adverse events were similar to the other studies. So you're not more likely to have a bad reaction or be less, have more safety issues if you've already had a history of zoster. So, as I've said, recurrence can occur, and actually rates of recurrence are greater in people who have had shingles before, and certainly in people who are immunocompromised. And the optimal time for administration following an episode of shingles is uncertain, but it's suggested to wait at least 1 year in immunocompetent people, but it could be given sooner in those with immunocompromised because they have a higher risk of recurrence. And if you are giving Shingrix, you still need to give 2 doses. In fact, there's no reason to only ever give 1 dose of Shingrix. People do need 2 doses. So it seems that some people have susceptibility to reactivation of latent varicella zoster virus and recurrence despite vaccination. Certainly in the Zostavax study, amongst those who developed shingles despite having had Zostavax, their rate of recurrence was the same as the people in the placebo arm. So Zostavax didn't prevent recurrent shingles. So what about Shingrix in somebody who has already had Zostavax? There isn't much evidence to support us, much information to guide us about this, but there's no safety concerns been identified. So it's suggested to wait at least 12 months after having Zostavax before having Shingrix, but this is just based on expert opinion. No studies really have looked at this, but most people should have protection from Zostavax for that first 12 months. And again, 2 doses of Shingrix are still required. And remember, Shingrix is not a treatment for zoster or postherpetic neuralgia. We got a query the other day hoping that it might help somebody with postherpetic neuralgia. Do you need to see if somebody's had chickenpox before? And it's not necessary with this vaccine to screen either verbally or with serology for evidence of prior varicella. In fact, we would discourage serology. Even if the person doesn't recall having chickenpox, you don't have to do serology. It's can be misleading with false negatives. And what about people who've had the varicella vaccine? Do they need Shingrix? well, this is a bit of a way off before we'll be thinking about this probably, but the virus in the varicella vaccine is a live virus, and although it's attenuated, it can establish latent infection and may reactivate to cause zoster. The risk of zoster is much reduced compared with wild type infection though. So I'm not really sure about the answer for this question. It is possible that people who've had varicella vaccine can get shingles, but probably the risk is going to be very low. So shingles is common and can cause complications and morbidity, as Buzz told you. We may in fact see more shingles because in the first year of the pandemic, an American study showed an increase in the rate of shingles in people following COVID, particularly if they'd had a severe COVID and required admission. The live attenuated vaccine Zostavax stocks are running out and there's not going to be any more, but we have this new recombinant adjuvanted Shingrix vaccine for people who can have it after their 65th birthday. If they have their first dose while they are 65, they are allowed, I believe, to have their second dose after their 66th birthday. It's recommended but not funded for anyone from 50 years of age and people with immunocompromise from 18 years. You need 2 doses, 2 to 6 months apart, and you can give it to people with immunocompromise. It's reactogenic, but more effective and provides longer protection than that provided by Zostavax. But just before I finish, I want to show you this graph looking at the years, disability adjusted life years lost for influenza, invasive pneumococcal disease, and zoster. So among these 3 vaccine preventable illnesses, there are far more disability years of life lost with influenza, that's the most, then pneumococcal disease, and both of them contribute more to disability adjusted life years lost than zoster. So remember these other vaccine preventable diseases.
Great, thank you very much to both of our speakers for such a thorough and good overview of the disease and our new vaccine. So a few questions coming through. First one is for Buzz. One practitioner is reporting one of their patients read online that getting shingles can give her MI or myocardial infarction or stroke even after recovering from shingles. What do you think?
That's wonderful. I'm always very suspicious about what people read online. Trump is a nice guy and the earth is flat. But nevertheless, interesting enough, this is one of those ones where they're 100% completely correct. There's between a 20 and 40% increased risk of stroke within the first 12 months of having had shingles. And the reason for that is that the shingles infection, which I missed out in my simplified talk, the shingles infection also induces a vasculitis. And it is highly possible that this increased incidence of stroke is not the either thrombotic or the hemorrhagic stroke, which we're sort of used to having, but this is highly likely to be a vasculitic stroke. Now, the important bit about that is if we genuinely see someone with a stroke happening within 12 months of having had shingles, it is very possible that they may well respond to a respectable and protracted course of steroids to shut that vasculitis down. So we just need to spread our diagnostic net a little bit further than we otherwise would do with something we otherwise would call, what a shame you've had a stroke, and I hope you get over it. So that's a really, really important question. Not everything you read on the internet is correct, as Abraham Lincoln once said. But on this one, yeah, spot on, absolutely, completely correct. Yeah, great question. So thanks for the opportunity to ask it. By the way, Joan, that was an awesome talk, by the way. Thank you very much indeed. Really enjoyed it. All
right, we've got a couple of questions about the vaccine for Joan. So a few questions just around the funding decision, I suppose. Is there any kind of reasoning behind why it's only for 65 plus, why we've only got that 12-month period from their 65th birthday, why it's not kind of above the 65?
I'm sorry, I'm not party to pharmac decisions. Those that's come from Pharmac, and we're in fact lucky to have it. They're not funding Shingrix in Australia.
Right.
So we've got to look on the bright side, I guess, but it's a Pharmac funding issue, which is not my remit, I'm afraid, so I can't answer those questions.
Sure, okay. Any comments about any boosters for Shingrix after you've had the initial kind of 2-dose course?
I mean, we still don't know the answer to that. As I said, it's expected to work for about 15 years plus. It's unlikely that you'll need a booster, but you know, we have to wait 10 years more. I think, you know, the people who were in the trial are up to sort of 8 years now. So wait and see, but I think it's a very effective vaccine and probably won't be needed.
Mm-hmm. And is there any benefit in giving the second dose closer to the first, kind of at the 2 months rather than waiting for the 6 months, or is there not much difference in efficacy?
Oh, I think it's about the same, yeah. It's good to do it at 2 months, but they may be more likely to forget if they don't get round to it.
Sure, okay. Do you know, for those who have already received a Zostavax, are they eligible to get a Shingrix?
Again, that's a funding issue.
Right.
I think, I mean, it would be good if they could.
Great, okay. And all right. Is there any reason to wait kind of a set period of time from when someone's had an acute shingles episode to getting Shingrix?
Well,
I'll dive in first with that one. If they've had ophthalmic zoster, very much so, they need to wait 12 months. The trouble is the vaccine's too good. And if they've had ophthalmic shingles and they are apparently in the recovery phase, so I would say 4 months after they seemingly recovered from ophthalmic shingles, the vaccine will go looking for any latent viruses which are hanging around inside the eye and set fire to them, and in turn then set fire to the eye. So there can be a very serious and nasty reactivation of an ophthalmic disease within 12 months of having had ophthalmic shingles. Bearing in mind that about 1 in 3 people with shingles will have ophthalmic shingles. If there's that Hutchinson sign where you sort of, I'm not rubbing my nose because it's itching, if they get the shingles sort of there on the nose thing, about 3/4 of them will also have ophthalmic shingles. So that genuinely deserves respect and the timeline. I'll now pass on to Joan because that was my little
no, I think you answered it. Yeah, very good.
Anything to add on that one, Joan?
No, I haven't really.
Do either of you know?
And the risk of recurrent shingles is lower in the first 12 months as well, as I showed on that graph.
Sure. Okay. Do either of you know how much the Shingrix vaccine is?
About $300, $320.
Okay, for each one, for each.
Yes. So it's not cheap.
Yeah, sure. Okay. Okay. Then, all right. One person says anecdotally they've seen a lot of younger people getting shingles. Have either of you noticed that or come across that or know any reasons for that?
The rate of shingles is increasing globally, and that has been seen in a study in New Zealand too that Nikki Turner did. So yeah, I don't know if it's very recent. I mean, maybe it's something to do with COVID, because the rate of shingles did increase in the study, as I said. The other thing is always think of doing HIV tests on people with shingles. In the receiving end at Auckland Hospital, we still keep seeing people with a late diagnosis of HIV, and they've had reasons why they should have had an HIV test, including shingles. So always think of that, of shingles in a young person.
Good point. Because the vaccine has that kind of 10 to 15 year efficacy, are we better to wait until they're 65 to get it rather than try and pay for it earlier?
Well, I've had it under 65, I've paid for it. So as Buzz said, the risk of shingles does start increasing after you turn 50. It goes up each decade. So, you know, you could we think the vaccine will work for a long time. It's completely different from the Zostavax, where you had this trade-off of it being more effective when you're younger, but then not lasting very long. We don't have to think like that now with this Shingrix vaccine. It works well at all ages, and it should keep working, you know, we expect for quite a while. And who knows 15 years from now whether I will need a booster, but I wouldn't mind paying for it again if I do.
Yeah, I 100% agree. In spite of my extremely youthful appearance, I'm over 50 as well, and I'm lining up as soon as I can get it. I'll get both. I just see on the Q&A it's popped up. Yeah, unfortunately, it is $600 for both. One could argue that the loss of productivity for getting shingles is a hell of a lot more than $600. But I personally, my extremely left of centre politics really gets saddened when that inverse care law gets reinforced and the people who need healthcare the most get it the least, and vice versa. And I personally would love to see it funded for everybody over 50, but I'm not the Minister of Health yet.
For immunocompromised, you know.
Right.
You know, some immunocompromised groups have rates of 50 or 80 per 1,000 per person years, compared with the general population of, you know, 11 or 9. So, you know, it would be wonderful for it to be funded for people who truly have immunocompromise.
Do we know, maybe a question for either of you, do we know if there's any evidence around kind of lifestyle factors, diet, exercise, obesity for risk of shingles or perhaps risk of postherpetic neuralgia?
I haven't seen that. I mean, females have a higher risk. Have you, Buzz?
Not really, apart from the fact if we just work on first principles, that the more immunocompromised we are, the higher is the risk. So interestingly enough, I get amused on a good day when I walk past a chemist shop and it says boost your immune system with X, Y, and Z. I'm sure Joan will agree with me. It's humanly impossible to boost the immune system. You just can't. But what you can do is you can suppress it. And interestingly enough, inactivity will suppress our immune system. So if somebody's deconditioned and inactive, then their immune system is going to be underperforming. And therefore, if we add the lifestyle factors to that, the more sedentary somebody is, the less immune competent they're going to be. And therefore, one could argue the higher the risk of getting shingles. And of course, then it follows the higher the risk of getting shingles, the higher the risk of PHN, which is going to follow that. So it's a little bit of lateral thought, but nevertheless, their basic principles. I'm extremely not aware of diet as an isolated factor, but needless to say, annoyingly, people who have healthy lifestyles seem to have healthy diets and vice versa. And that just seems to be a crude observation. That's as good an answer I can give. Mindful of the fact I've got a infectious diseases expert I'm staring at our screen here. Did I speak out of turn there, or
No. Yeah. Sounds sensible.
Do we know, is there any difference in ethnicities for those being prone to developing shingles or postherpetic neuralgia? You know, should we be encouraging them to maybe pay for the Shingrix a little earlier?
Whoa, that's a good question. Now then, I'm going to throw this right at Joan, because I'm very respectful of the fact that here we are in Australasia, and if we look at nearly all-cause mortality and morbidity across Australasia, the Aboriginal and Indigenous people over there have an increased incidence of everything between 15 and 20 years younger than the non-Indigenous people do. And I think our Maori Pacific people here sadly are facing the same inequities of disease. So very good question. I am just reframing the question without giving an answer. Joan, I'm desperate to know what you think on that one.
Well, I'm just trying to think about Nikki Turner's paper. I'll have a quick look for it. That recently looked at shingles. If you want to talk about something else while I quickly look to see if it was an ethnicity difference or not. I don't think there was, but
I'll ask Buzz a question while you do that.
Yeah.
You mentioned sometimes giving kind of steroids in that acute shingles kind of syndrome. What patients would you consider that in?
To be honest with you, nearly every patient, in my view, it should be default setting. We shouldn't be saying, should we give them? We really should be saying, why should we not give them? And I would have thought, really, unless somebody's had a major psychotic episode, or they hitherto have had a complete destabilization of the diabetes with the previous course of steroids, they really should be getting it. What that course is has not been standardized. So if it's 40-day for 5 days and 20-day for 5 days, or 30-day for 10 days, it really almost doesn't matter. If it's less than 2 weeks and it's a respectable dose, it will shorten the severity and the duration of the shingles itself. Annoyingly, the data has not emerged as yet that in so doing, we will reduce the risk of PHN. It'd be wonderful if we did, but I'd be misleading you. I'm not aware of that data.
Okay. So for most patients, you'd be considering a course of, say, prednisone alongside valacyclovir.
Yeah, and that's been relatively standardized probably over the last 5 to 10 years. Prior to that, absolutely not. It was a Paris thought they're immunocompromised, and that's why they got it. We're not going to immunocompromise any further, but that has well and truly been sidestepped. Again, I am here. Joan, tell me I'm not speaking completely out of turn, or if I am, please be polite about it.
I wasn't listening. I've got my answer to the question.
I'm sure Joan will agree.
I can answer the question that we were wondering at. There was fewer this was looking at consultations for shingles in New Zealand, and there were fewer consultations for Maori and Pacific people, and there was no difference by socioeconomic status.
Okay. Good to know. Thank you. Thanks for looking that up.
So that's New Zealand data on that, on ethnicity.
Question for Buzz. If someone's maybe developing that postherpetic neuralgia, I know you said the kind of time frame for diagnosis was about 3 months, but if they're kind of having pain weeks to months after their shingles episode, should we be considering things like gabapentin a little earlier? Is that going to improve their course? What would you recommend?
Absolutely. The 3 months, to be honest with you, although it is a strict definition as regards therapeutic intervention, it's a guideline. Certainly to the development of acute to chronic persistent pain, one could argue starts sort of 1 or 2 days after the acute nociceptive insult. If clearly someone they've had the shingles treated and the pain is well and truly outstaying, welcome, especially if they've got those risk factors of a severe prodrome, a high temperature, a nasty rashes in many different parts as well, and the pain is outstaying its welcome. Do not wait for the 3 months and set your stopwatch. Dive in early with neuromodulation, because the sooner we get in with the neuromodulation, the sooner we can endeavor to try and put that fire out, and in particular try and desensitize what is becoming a sensitized central nervous system. Really good question, and I hope my answer isn't too woolly. I'll bring my answer into focus. Yes.
Yeah, correct. Okay. A couple of queries around acute treatment as well. Prednisone, you mentioned we're not too sure in terms of duration. Anything will help. What kind of a dose would you be giving?
Right, there's 2 regimes to go for, 30 a day for 10 days or 40 for 5 days and 20 for 5 days. They're the 2 regimes I've read.
Great, thank you. Okay, and are we preferring valacyclovir to acyclovir in the acute situation?
Joan?
It's got better bioavailability, and you don't need to take it so frequently, so it's got advantages. Yeah.
Great. Pregnancy, is that a situation where we maybe should be thinking about the Shingrix vaccine? We've got someone who has seen quite a few pregnant women with shingles.
Well, I think they could wait till after pregnancy probably, but you know, it's not a live vaccine. So if they desperately wanted it, I suppose they could. It would say on the data sheet not to, just because of not had the trials.
Sure.
And if they're pregnant and over 50, well, congratulations, that's fantastic.
Yeah.
No, they could be immunocompromised.
Yeah. Is there any evidence that regular exposure to children with chickenpox, for example, school teachers or primary practitioners, is more protective against shingles?
Well, we don't really know. We used to think it was important. Certainly boosting your immune response to shingles helps prevent, to the virus helps prevent shingles, but it's probably more intrinsic boosting. So your virus levels just increase a bit in you and that boosts you, rather than extrinsic boosting from people with infection. Maybe extrinsic boosting within the family is important, but not probably more distant boosting. But it's a really good question. We don't know what the threshold is for people's virus replicating, and we have this theoretical idea that it gets boosted by exposure, but it's probably more innate boosting rather than extrinsic.
Great, thank you.
So we've still got to learn more about that.
Sure. Question probably more for Buzz. Is there a shelf life for postherpetic neuralgia? For example, how long could it last for? And is there a typical time frame between kind of getting the acute rash and getting postherpetic neuralgia? Can there be a delay there as well?
Yeah, look, really good question. That's sort of a question in two halves. One could argue that postherpetic neuralgia is where the pain did not go away and it's outstayed its welcome and it's persisted for 3 months after the original shingles insult. So that's a sort of a definition thing. It is very unusual to get shingles, have a painful shingles, pain completely go away, and then it come back again. It's more a persistent pain, and hence that slide I showed where the AMPA receptors give way to the NMDA receptors because they're constantly being stimulated. So in the first instance, I hope I've answered that question. How long will it stay for? Really good question. It varies from cohort to cohort, but as a crude rule of thumb, more than 50% will persist for more than 12 months, which is a well and truly outstayed its welcome phenomenon, and hence the reason to try and get in a neuromodulator as soon as possible. And the disability and the impact on the functional status of people with postherpetic neuralgia can never be underestimated. It's I think it's something like, I'm making this figure up, but it's coming from somewhere. I think if people have not managed to get back to work by 12 months because of postherpetic neuralgia, they've got well over 50% chance of never getting back to work ever again, irrespective of who they are, where they are, what their age is, as long as it's over 50. So it's yeah, good question, but unfortunately it does outstay its welcome.
Sure. Okay. Maybe more of a question for Joan. You mentioned that those, for example, getting was it chemotherapy, the Shingrix vaccine might be more effective if they have it before they start. Is there any need to get, I guess, with any immunosuppressant kind of treatment, is there any need to get boosters after they've finished their treatment?
That hasn't been studied. So yeah, like a third primary for COVID or something, no. So that's why you do want to think a little bit carefully about when you give the vaccine and try and maximize its effectiveness by giving it at a less immunosuppressed time if possible, or prior to immunosuppression ideally.
Sure.
These are really good questions, by the way. I'm just I'm really impressed.
I'm going to jump back to Buzz now with postherpetic neuralgia. At what point would you start to wean people off neuromodulators? Do you want to keep them going for a little longer after their pain's kind of resolved? What's your approach?
Do you know, that's $1 million question. It is possible to stop them too soon. It is impossible to keep them going for too long. So that's a sort of a nice opening paragraph, but no, totally fair question. One can argue if the symptoms really have been extremely well suppressed and the fire has been put out, that is fantastic. Then it would be wise to keep the fire put out for a minimum of 3 months before starting to wean off. by and large, it's a lot of people are when we're going for the pharmacological wing of that, are genuinely going for synergy between a gabapentinoid and a noradrenaline reuptake inhibitor. And so when it starts to wean off, obviously we stop one first and then stop the second and wean off both. When it comes to weaning, weaning's kind in numerous directions, but probably the most important thing is that stopping anything abruptly is like stopping a car abruptly and making somebody fly through the windscreen. So a gradual weaning process of both is just kind and sensitive. In addition to which, of course, it will give us feedback as to whether we are temporarily suppressing something which will come straight back as we take our foot off the brake, or whether we genuinely have put the fire out. Interesting enough, for a lot of people, we really have, and if we've managed to desensitize a sensitizing central nervous system, we are appropriate to deprescribe. But as a again, long answer, I'll cut it short. Minimum of 3 months after satisfactory suppression of symptoms before we start weaning would be very orthodox.
Right, okay. So continue for about 3 months after pain stops.
At least, yeah.
Perfect, thank you. All right, thank you both very much. I think we'll end the questions there. Thank you for very thorough presentations. I sure learned a lot.
Joan, thank you.
Thank you everyone for joining us, and have a good rest of your night.
God bless you. Good night and thank you.